Good afternoon, everyone. I'm Anas Farooq. I'm one of the Nephrocritical Care Fellow, and I'll be presenting Journal Club today. Can you guys hear me okay? Okay. So my mentor for this presentation is Dr. DeGiovanni, and the article I'm going to talk about is the effect of buffered crystallite solution versus saline on acute kidney injury among patients in intensive care unit. It's a split trial that was published in JAMA by the end of 2015. So there has been discussion for a while that chloride-rich fluid results are actually associated with hyperchloremic metabolic acidosis and also AKI as well as mortality. But those things are kind of proven by only observational studies and animal studies. But this study kind of present like a landmark trial regarding this. So a little background about the chloride. Chloride, even though we tend to ignore chloride a lot since we take care of our sodium, bicarb, potassium a lot, and that's the last one we usually look about. But chloride is the most abundant anion in the extracellular fluid and plays an important role in the immunomodulation as well as in the acid-base balance, osmosis, and everything. As I said, use of hyperchloremic solution has been linked to increase the risk of acute kidney injury and mortality, but those studies have inconsistent results, and those are only observational as well as like animal studies, but not being proven by randomized controlled trial yet. So the proposed mechanism by which chloride-rich fluid can cause AKI is that renal vasoconstriction leading to renal hypoperfusion and the renal interstitial edema that leads to intracapsular hypertension resulting in AKI. These pathophysiologic mechanisms in linking chloride load and mortality are less clear independent of AKI, even though we have proven that these things can, the hypochloremic fluids can cause AKI, but how these are linked to the mortality has been less clear. And as I said, those observational studies has not have any good evidence for that. Maybe augmented pro-inflammatory responses or diminished coagulation ability that we see in the patient with hyperchloremic metabolic acidosis can play a role, but the benefit is not, but the evidence is not sufficient for that. So looking at the chloride effect on the kidney, when you give like hyperchloremic fluid to the patients, it will result in the hyperchloremia in the afferent arterioles, and which will increase the chloride load in the renal tubules, resulting in decreased proximal tubular reabsorption and increased delivery of the chloride towards the macula densa. That will be taken up by the macula densa with the basement membrane, and it will cause the depolarization there and increase in the adenosine, which will result in the further vasoconstriction as well as AKI and the decrease in urine output. So that's something chloride can do with your kidneys, but that's a proposed mechanism we have at this point. But none of those because we do not. But at this point, we do not have any evidence that how they cause the mortality. So before we go further, just a brief talk about a little bit a difference between balanced and unbalanced solutions. When we say balanced and unbalanced solutions, so those solutions which have like electrolyte composition which is close to the plasma are called balanced solution. Like you see on the left side, you have plasma with electrolyte composition like we see normally: sodium 140, potassium 5, chloride 100. This calcium, it says 2.2. It's a different unit than we see in our normal chemistries. Here, here it is milliequivalents per liter, but in the normal chemistries we see it's milligram per deciliter. So when you compare it with the normal saline, and when we give patients a normal saline like an unbalanced solution, you see that there's a high chloride content in the saline, and that is as compared to your plasma. And when you compare it with the other of your balanced solutions like Ringer lactate, Hartmann solutions, or plasma light, you see that their composition of electrolytes is much similar to the plasma. And in fact, plasma has that plasma light has acetate of 227 in it too. That will actually convert it to the bicarb, and this is a more alkaline solution as compared to the Hartmann or Ringer lactate solution. So that's a little bit background about the study. So the objective of this study to determine the effect of buffered crystallite solution compared with saline on the renal complications in the patients admitted to intensive care unit. So there was randomized, cluster randomized, double-blinded, double crossover trial conducted in 4 ICUs in New Zealand from April 2014 through October 2014. 3 ICUs they enrolled were general and medical ICUs, and 1 ICU had a predominance of cardiothoracic and vascular surgical patients. We'll start our critical appraisal, and we'll be talking about the patients, interventions, comparison, and outcome about this trial. So the participants, as I said, that from April 2014 to October 2014, they have like a good amount of numbers. More than 22,000 patients were eligible, were enrolled in the study, and they were in the 1162 patients were assigned in the buffered crystalloid group, and the 1116 assigned to the saline group. Of the enrolled patients, most of them, like 99% in the both groups, like 1152 of 1162 and 1110 of 1116 patients, they were actually completed the study and were analyzed. Most patients were admitted to ICU following elective surgery, most commonly cardiovascular surgery, and relatively few had comorbidities. So the inclusion criteria they used for the participants in the study was all ICU patients receiving crystalloid fluid therapy as clinically indicated were eligible to be included. Essentially, everybody who's been admitted to the ICU was included in the study except those who were on renal replacement therapy for end-stage renal failure, or those who are receiving renal replacement therapy or expected to require renal replacement therapy within 6 hours, or admitted to ICU solely for the consideration of the organ donation or palliative purposes. So 4 ICUs were included in the study, and out of those 4 ICUs, 2 ICUs randomized to receive alternating 7 weeks blocks of treatment, either saline or plasmalide, which is the buffered solution they use, for the total of 28 weeks period. So they used 2 crossovers, and they were treated for each 7 weeks for total of 28 weeks, and they were using alternating fluid, 1 week with saline, 1 week with bicarb fluid, buffered fluid. So by the end of the 2 crossovers, and by the end of the analysis, they found that there's like 1067 patients were in the buffered crystalloid group, and 1025 patients were in the saline group. So almost both samples, we have like sample size of like more than 1,000. So plasmalide versus Hartmann solutions in New Zealand, they have both plasmalide and versus they have both Hartmann solutions and plasmalide. But the reason they use plasmalide because that was most widely available, and also because the Hartmann solution has calcium in it, and that calcium is kind of incompatible with the preservation of the blood sample with citrate containing anticoagulants. So 2 ICUs initially used 1 fluid, and the other 2 ICUs used alternative fluid. So the 2 crossovers occurred so that each ICUs used each study fluid twice over 28 weeks. For the 28 weeks, each ICU used 1 fluid for 7 weeks, and then the other fluid, and then the other fluid, and there were 2 crossovers. So study fluid appropriate for each study block were provided in 1,000 milliliter bags labeled as fluid A or fluid B, and the study fluids were microscopically indistinguishable. Investigators and clinicians were blinded to the fluid and allocation for the duration of the study. So regarding the composition of the fluid that was administered in both arms, so one was the buffered solution like plasmalide, and the other one was the normal saline. As you can see that there's a significant difference of chloride in both of these solutions. One has like 98 close to the serum, and the other one has like 154, which is kind of like higher amount as compared to the buffered solutions. And the fluid volume they administered, that was the volume of the in the both groups. In the both buffered solution and the saline groups, they administered almost like total of 2 to 2.6 liter of the fluid, with major chunk of the fluid that was given in dose 0, which was like 1 to 1.7 liter in both arms. But by the end of the the total fluid that was given was actually almost 2.6, 2.5 liter. So the comparison they used with this study design with double crossover study model, each group has served at its own control. when the respective fluid is not being administered to the same group. Like we see in the crossover trials, either we have like parallel groups or the crossover groups. After the crossover, the group that was the intervention will become the control group, and the control group become the intervention. And they use two crossover so that each study group will kind of serve as its own control during the time when they were not receiving that sample, the fluid. So the outcome. So the primary outcome they said for the study was the proportion of the patients with AKI as defined by rifle category. The rifle category is a kind of consensus definition for categorizing the patient in different categories depending upon the AKI. R stands for like risk of kidney injury. I stand for injury, and the F stands for failure. L stand for loss of kidney functions, and E stand for end-stage renal disease. So, and the secondary outcome, cumulative incidence of AKI as defined by rifle category as well as KDIGO criteria. So with AKI, we defined on the basis of two different criteria. One, a rifle category, in which we say that, okay, if there's 50% increase, there's a risk of kidney damage. If there is like a doubling of the creatinine, there's like it's an injury to the kidney, and if there's like the tripling of the creatinine, then there's a failure, and the persistence of failure is called loss, and then so on with end-stage renal disease. However, in the KDIGO criteria, we define AKI like 1.5 the increase of creatinine by 1.5, and then 1.5 to 3 is a stage 2, and then more than threefold is the stage 3 of the KDIGO criteria. So the secondary outcome they used within 90 days of follow-up were the cumulative incidence of AKI as defined by rifle category and KDIGO criteria, use of RRT in the ICU, and the requirement for the RRT after hospital discharge. The ICU and the hospital length of stay, the ICU and in the hospital all-cause mortality and all-cause specific mortality as well. All analyses were conducted on intention to treat basis. There was no formal power calculation were performed, and the binary outcomes were compared using the relative risk, and the continuous outcomes were compared using the mixed linear modeling for the study. So regarding intention to treat, since they made their analysis on the intention to treat basis, so the intention to treat is actually when all the participants who were randomized in the statistical analysis were included, even though, and they were analyzed according to the same treatment group to which they were randomly assigned, regardless of what treatment, regardless of for what treatment they received. And even if they refuse or discontinue the intervention, cross over to another randomization group, a missed follow-up measurement, or otherwise violation of the study protocol, but still they will be analyzed in the same treatment group they were initially assigned on. That actually, the advantage of this intention to treat analysis is that they tend to decrease the bias in the comparison of the two groups, and that actually they use for that. So there was the assignment of the patients, so the treatment was randomized. Yes, they used the cluster. I'll go over the questions we have for the critical appraisal for the JAMA articles. So was the assignment of the patients to the treatment was randomized? Yes, cluster randomized trial that was, and the participating ICUs were assigned to use blinded fluid, either saline or buffered, for alternative treatment blocks of 7 weeks, with initial determined by the study statistician using computer-generated randomization. So the types of randomization, we have different type of randomization we use in our clinical trials. The types of randomization with the simple, block, which is cluster, the one we use, stratified, and covariate. The simple randomization in which each individual is randomized to each of the treatment group. In the block randomization or cluster randomization, the whole group of the people of the individuals rather than the individuals are randomized to the treatment group. And the stratified randomization is the one they have like homogeneous subgroups of members, which are kind of divided into separate strata, and after that they are kind of randomized. So looking at the groups of the study, so looking at the characteristic at the baseline of the study. So with a glance, you will see that the patients or the participants on the both study group were kind of similar. But I would like to point out on the few things that are kind of really important in the appraisal of this article. Is first of all, look at the ethnicity of the patients that were enrolled in the study. I mean, they were European. The study was done in New Switzerland, so they were European and Pacific Islander mostly, different from the ethnicity of the patients we treat here. Other than that, source of admission to ICU. If you look at the source of admission to the ICU, you will see that most of the patients were admitted to the ICU from the operating room. They were kind of post-op patients. Like you compare 822 and 798 patients in both groups were kind of admitted from the after the surgery, and 650 and 642 of the patients would have like elective surgery at that time, and there were only few patients who were admitted for from the emergency department, like 168 or 148. So that's something which is it's really important to look at the characteristic of the patients that were included in the study. And if you look at the Apache score of the patients, the severity score of the severity of their illness is the mean was like 14.1, much less sicker than the patient we normally see in our ICU. The other thing was there was fluid that was administered before enrollment in the study. Each study group received 1 to 1.5 liter of the fluid before enrollment in the study. And if you look at the subgroup analysis of the patient, you see that the sepsis patients are really few in the study. Out of that 1,000, I mean, you see the sepsis patients were like only 41 and 43 in both of these groups. And then they have like trauma patients, and the mean Apache score more than 25, they had only like 95 and 87 of the patients. So that's something really important in the appraisal of to look for the characteristic of this study population in both groups. So aside from the allocated treatments, were the patient treated equally? Yes, they were treated equally, and the same treatment and the follow-up, and the personnel were blinded for the study as well. So were all the patients who entered the trial accounted for? Yes, as we mentioned that we had they analyzed the patient on the basis of intention to treat, and all the patients who were included in the study were accounted for it. So were measures objectives, or were the patient's clinician kept blinded to which the treatment was being received? So the study fluid prepared for each study block were provided in like liter bag, and with fluid A or fluid B, the study fluid were microscopically indistinguishable, and investigators and clinicians were blinded to study fluid allocation for the duration of the study. Patient who remained in the ICU through more than one crossover periods continued to use the same fluid to which they were originally assigned. So what was the result? So if you look at the results of the study, and if you look at the primary outcome, first of all, we'll talk about that. So the primary outcome of the study was development of AKI during that hospital stay, and that was based on the rifle criteria. If you look at it, you see that the primary outcome of the study, you don't see any significant difference in the development of AKI in both groups. Even either the buffer crystallite solution or the saline groups, you see that the relative risk was like 1.04, and with a confidence interval of like 0.80 to 1.36, with a p-value of like a 0.77, which is not statistically significant at this point. So other than the primary outcome, if you look at the significant secondary outcomes of the study, you see that one of the significant secondary outcome of the study was the use of RRT during that hospital stay. You don't see any significant difference in the requirement of the renal replacement therapy in both groups. It's almost the same, and the confidence interval is not significantly different either. If you go down to the list, you see that you have inpatient hospital, like ICU days and hospital days, and the main mechanical ventilation days. You don't see any significant difference in any of the results of the both treatment and the both saline and the buffered solution group. And if you look at the mortality as well, even though our few previous observational studies had proven that we have some saline are known to cause increase in the mortality of the patients, but if you see both in death in ICU and death in hospital, you don't see any significant difference in the results of both the buffered and saline groups there. So the proportion of the patient who are requiring renal replacement therapy like until like day 90 or after the enrollment. If you look at the both groups, you will see that the patients who were requiring renal replacement therapy in both buffered solution and saline, you don't see any significant difference either. And they actually followed those patients to up to 40 days, because after that, after the 40 days, they did not have that much patients over there, so they just followed them until the 40 days, and they don't see any significant difference in the patients with the buffered crystallite solution and saline. So if you look at the subgroup analysis for the risk of developing acute kidney injury in the both in the both saline and the buffered crystallite solution groups, you will see that as we discussed, we do not have any significant difference in the both groups. And you look at the odds ratio for developing AKI in all of these, you see that it's almost similar, and with almost the same confidence interval. But again, the thing to point out here is that the sepsis patient, how many sepsis patients were they seeing in their subgroup analysis? The patient who had sepsis in both groups, there were only 35 and 42. And the patient who did not have sepsis in these both groups, you see that in the buffered crystallite solution, you see that it's almost 1,000, close to 1,000 in the both groups. But the patient who did not have sepsis were only few in these patients. As well as if you look at the Apache score of these patients as well, so that mostly they were not that sick, like we see patient here, that as compared to them in the both groups, and those results were kind of not significantly different either. They also look for the serum creatinine for the buffered crystallite solution versus saline groups. And if you look at the baseline serum creatinine, they defined as the one they measured 6 months prior to the study. And the pre-study fluid therapy creatinine was the one they measured like 24 hours before enrollment in the study. And they treated patient with both buffered crystallite and saline solution, and they found that they did not see any significant difference in the development of AKI, because the rate was the same in the uptrend or the creatinine difference as well. So the summary of the results, that there was no significant difference in the primary outcome or the incidence of AKI in both groups, like with buffered crystalline solution as well as saline groups. There was no significant difference in the key secondary outcomes as well, like we discussed: patient who were requiring renal replacement therapy, patient who were developing AKI with the following like 90 days period, ICU mortality, in-hospital mortality. They also look for like days of ventilation as well. They did not see any significant difference in the patients in both saline group as well as for buffered crystalline solution group. So that was the summary of the results, and the conclusion they made that among the patients receiving crystallite fluid therapy in the ICU, use of buffered crystallite solution compared with saline did not reduce the risk of AKI. However, further large randomized clinical trials are needed to assess the efficacy in the higher risk groups and to measure the clinical outcomes as such as mortality. So how well the study was conducted? So that was double-blinded randomized control study, and that was double-blinded cluster randomized study, and they had like statistical plan that was published before the recruitment to the patient to reduce the analysis bias, and the primary endpoint was derived from the serum creatinine measurement that was reducing the observer bias, and that there was negligible selection bias either. So the basic limitations of the study we had that actually will kind of affect in the interpretation of the study was that there was only small number of sepsis patients in the both study group, and the small volume of fluid was administered, like 1 to 2 liter of the fluid volume that was administered, and also the pre-enrollment fluid that was administered before they were enrolled in the study, and that can affect our results as well. And if you look at the Apache score, the mean was like 14.1, much less than the patients we see here, and obviously the ethnicity was the different, and also there was no sample size calculation as well. So will that result help me in caring for my patients or changing my approach towards a patient? First of all, there was a negative study, and again, there was only few number of sepsis patients that were enrolled in the study, and again, the volume of the fluid that was administered during the study was really small, and we have like some fluid that was administered before in enrollment in the study, and critically ill patients with low overall mortality were enrolled in the study. So if I have to make the decision conclusion to what to do for the patients with hyperchloremia and for the patient requiring large amount of fluid, I would try to avoid chloride-rich fluids, because if you look at the studies, all those studies have proven either no difference or they have proven harm. But none of those studies have proven that any benefit of using chloride-rich fluid in the patients for the resuscitation and was as well. So this is the same conclusion that was an editorial published by Dr. Yasain. Most of you know Dr. Yasain, and he actually published this editorial this year that has the time come to abandon chloride-rich resuscitation fluid, and he ended up with a really good endnote that despite inconsistencies in reported outcomes, it is notable that nearly all studies suggested an association with adverse outcome, and there are no studies that report beneficial effect of chloride-rich fluid compared to the balanced solutions. So in other words, there's no evidence of the benefit, but quite possibly some harm. So that's why clinicians may wish to minimize chloride load when administering large amount of crystalloid or in a patient who presents with hyperchloremia. So what is out in the literature? There's a study right now going on in Vanderbilt, and they are actually trying to look at the balanced crystalloid versus saline in the intensive care unit, a study protocol for like the cluster randomized multiple crossover study. I hope that they will enroll more sepsis patients. I hope that they would not have those limitations we have with the previous studies, but this is out in the literature, and we do not have that study published yet, so we'll wait for that. So that's all I have. Thank you so much.
Very meticulous review, very good. Couple questions. You look at the pH of normal saline, it's 4 to 5. Where the pH of balanced salt solution is near normal, physiologic. Was that addressed?
I did not see any addressed by them for regarding the pH for the patients.
Because if you look at when you give fluids and you already got an altered pH, such as a shock patient, and
Right.
you're throwing them chloride,
Right.
it's not the fact that the fluid's bad, it's just that you're giving them a solution that's not appropriate for their
Right.
acid base status. And then you confound these patients who have acute kidney injury if they're quote unquote in shock. Then you got two issues that you're just basically giving them the wrong fluid. So it's not a matter of the fluid that's bad, it's just the clinical indications
Right.
in that patient population.
Yeah, I didn't see any comment from them regarding the pH or like acidity of the fluid, but there was something we need to look for. Yeah.
Did they look at the chloride level for groups and like hyperfluids, hyperchloremia and stuff?
There wasn't anything mentioned regarding chloride levels either.
Or before
Yeah.
they were randomized, there was something that
They basically enrolled all the patients recording fluids, and I mean they were not categorized regarding their levels for chloride at this point. So
They did not comment on the composition of the operated crystalloid solution.
no, they did comment. Maybe you came a little late. We had that.
higher than
Yeah, so they did comment on the composition of the fluid that was administered. So no, they did not. They did not say anything about the chloride levels of the patients. Yeah, they did not say anything about that.
Just one more comment. Bruno may know this better than I, but when the FACT trial, what they did is a fluid management strategy in acute lung injury. And they did an analysis of race. And what they found is that black patients get worse because they have the aldosterone axis is more stimulated because of hypertension and a lot of things. Fluid spill. So the carefulness, and you brought it out appropriately, is you look at the racial composition of your patient population.
But they were not African American numbers. Yeah,
you,
they were not American.
you basically generalize. The generalizability is limited because
Yeah.
you got physiologic effects. They have more salt retention in black patients.
Right.
So the adversity may be greater based on the racial predisposition. So it's a very nicely put trial, but just
have some
basically
limitations.
patient population
Yep.
makes generalizability limited
Yep.
in certain patients.
Right.
We're already starting with the percent of patients who have pneumonia generalists. So the power to detect the difference, it's not very high. Number of patients with disease that could be affected by the treatment,
Right.
which goes to the low action.
Mm-hmm. Yep. Yes. Yep. Thank you. Claudia, do we have to do something?